Greetings from Billman Group of Institutions. We are today taking an interactive question and answer session. Repeating, this is an interactive question and answer session for those who are registered with us for different server-based courses. This is not a course right now what we are conducting, but a question and answer session for those who are undergoing different server-based courses with us. We have got a list of questions with us, and I will show you the list also. So I am having with me this list of questions. I will display this on screen also, and we will be taking these questions for interactive sessions. So this is the list of questions with us. The first question from Dr. Sai Nivedra from Tamil Nadu is that these are copy-pasted questions. What I mean by copy-pasted questions, that as we copied and just pasted it over here, so the language is original. I have a query regarding uterine artery, sir. How to check the uterine artery in term patients? It means that how we have to check for the uterine artery in a term pregnancy. That is a question from Dr. Sai. Next question is how to differentiate between a dominant follicle and corpus luteal cyst, and how to measure a follicular size. These are two questions from Dr. Neha. And next question from a doctor from Odisha by the name of the Subhalakshmi is regarding the focal zones, how to change these focal zones, and so on. So I will be taking these questions. We are having about 10 to 15 questions today. And first question from doctor, I am having a list as already told with me. From Dr. Sai is that I have a query regarding the uterine artery, how to check the uterine artery Doppler. Now, first of all, please be very clear that a uterine artery in a term pregnancy is not having so much significance. When I say term pregnancy, I will not be much concern about the uterine artery, because the uterine artery has done its job in a second trimester, because uterine artery is more for prediction. Okay, but I have to take, but the point is I will not be more concerned about the uterine artery in a term pregnancy. The question here is how to check for the uterine artery. The uterine artery, as already discussed with you in class, if you have completed the color Doppler course, there are multiple practicals where we have demonstrated how to take a uterine artery in a second or a third trimester term pregnancy. Of course, in a term pregnancy, the baby will be occupying more of space. You have to settle your probe between the pubis symphysis, and then you have to angle it. Now see, you have to angle it. You have to fan it, like over here. You have to fan it towards the right and towards the left side to see for what? Not the uterine artery. You will forget about the uterine artery for 10 seconds, because a bigger artery, a bigger vessel, I will say, is the iliac vessel. If you will be getting a iliac vessel first, confirm that that is an iliac vessel, not a ureter, because they are very adjacent to each other by color. Putting a color, you will not get this ureter filled with color, but you will get an iliac vessel filled with color. Why I am saying iliac vessel first? Because whatever is crossing is the uterine artery. So then see for the crossing vessel. So the technique is first get your iliac vessels, and the uterine has to cross it. Automatically the uterine will pop up. But if you will search for the uterine artery, you may get puzzled, why is the uterine artery? So better to search for the iliac vessel and see for a crossing vessel. So in term pregnancy, the technique is same. You have to tilt towards the side by tilting the probe, not fanning only, but tilting the probe like this over here toward the right and to the left side of the uterus. Then regarding the flows, that is a detailed topic which is there in the color Doppler. You have to see whether there is notches, whether there is a good diastolic flow, and so on. So the basic question was how to check for the uterine artery in a term pregnancy. I hope that I have answered Dr. Sai Nivedri's question regarding the uterine artery scanning in a term pregnancy. Next question from Dr. Miha is that how to differentiate between a dominant follicle and a corpus luteal cyst. And the second question is from same Dr. Neha, how to measure a follicle. Now, when I say, try to understand, when I say a follicular cyst, and when I say a corpus, this luteal cyst, corpus luteum, first of all, the corpus luteum, this is in detail in gynae ultrasound courses. I suggest you to go back to the gynae ultrasound. Things will be much more clear in a course over there. So in corpus luteum, what will be the echogenicity of the corpus luteum? First of all, the corpus luteum does not have any fixed echogenicity. It can be anechoic. It can be hyperechoic. It can have a mixture of echoes, that is the heterogeneous. But the basic question is, what if it is a rounded structure, not a hyperechoic structure? First is the echogenicity. There will be some echoes in a corpus luteum as compared to a dominant follicle. There will be, yes, repeating, there will be some echoes. So if you are seeing a follicle looking like, and if that corpus okay, done. So I was telling you the last point, why you are opening only one eye of yours. Try to understand what I'm saying. You have to see to the endometrium as well, because if endometrium is showing you some change of the follicle being ruptured, it means that you have to keep an eye on the endometrium also. And if endometrium is giving you a hyperechoic, a luteal phase change, secretory endometrium, hazy tri-laminar pattern, or an increased echogenicity, it means that whatever you are seeing over there, the follicle in inverted commas is not a follicle but a luteal corpus luteum. So this way you can differentiate between a dominant follicle and a luteal cyst. So next question from Dr. Neha, same doctor, is how to measure the size of the follicle. Now see, the size of the follicle, don't take only one measurement. Now see over here, I'm drawing it over here. Don't take only one measurement like this, because many a times you will not be having a round circular shaped follicle, and you have to then take two measurements like this. For example, here I am having 22 and here I am having 28. Then I have to give it 22 multiply by 28 millimeters of follicle. So take two measurements of follicle, not only one. So these were questions from Dr. Nihar. Now the next question from Dr. Sabha from Odisha is regarding the focal zones. Now see, we are in machine, we are having many buttons, many knobs over there, and one knob is a focal zone. We have taken this in detail in physics and machine settings, how to move these. I will suggest this doctor to revise the class of the physics. There is a class of knobology, is about a 40 minutes class, and there we have discussed in detail regarding these focal zones, why these are important, when to change these focal zones and all. But as the question has been posed, I have to answer it in brief. So now, yeah, got it. Okay, so regarding the focal zones, now regarding the focal zones, there is a button in machine, it is over here. There is a button in machine by which I can increase the focal zones, or I can even decrease the focal zones, and I can move these focal zones toward this side or towards this side. So I will not discuss over in detail over here what for these focal zones are. Okay, because this thing is already covered in detail in knobology class. So the answer to the question is that there is a knob. You have to search for that knob, and it has to be here. It is the here in this machine. In your machine, I don't know where that knob is. Okay. Now, I'll give you a brief that why I need sometimes only one focal zone and sometimes I may need multiple focal zones. Now, for example, now to understand, for example, here I am using one focal zone over here. See, this is the focal zone over here. Let me draw over it. This is the focal zone over here. Now my area of interest is over here. Try to understand. My area of interest is over here. This is the fetal pole over here. So I want machine to focus more onto this area. Oh, see, because my area of interest is over here. So I will be keeping this focal zone near my area of interest. Now, why I should use two focal zones? Now, if, for example, if there is another area of interest, if there is another area of interest, let me take another color. If another area of interest is over here, okay, for example, two fibroids. Let's take this is a fibroid over here, and another fibroid is over here. Now, what I want over here in this given case, I want one focal zone over here so that it can show me a better resolution of this area as well as this area where the fibroids are. I am not concerned about this area. I am not bothered about this area, and I am not bothered about this area. So I will move my focal zone as per my area of interest, and whenever needed, I can switch from a single to multifocal focal zone. So these were the questions from Dr. Subhalata. And one more question from Dr. Subhalata is regarding the Cine lobe. Okay. Now, what a Cine lobe is? Now, a Cine lobe. Now, see, whenever you are scanning, try to understand first. Don't read for now. Whenever you are scanning, your machine is always recording for you the previous pictures. I mean, maybe 2 seconds, 5 seconds, 10 seconds. It is recording for you the captured image, whatever you have captured during previous 5 seconds or 10 seconds. Now, a Cine lobe, what a Cine lobe is? Cine lobe is a series of ultrasound images which is captured in sequence by a machine. Now, why I need this Cine lobe? How to get this Cine lobe first? When you freeze the machine, I mean, when you press onto the freeze button, you will scroll down. Scroll down by your trackball. You will scroll down by your trackball, and you will see that the machine will play a small clip for you, and that clip is the image captured in sequence, the last image. I mean, now why I need these images? Because sometimes patient is not cooperative. Maybe that patient is moving here and there, and patient is not cooperating with you. You will be recording it, and you will be scrolling down to see what I have seen while the patient was moving over there. Number one. Number two, if there is a contraction, muscle contraction, for example, you are doing a biophysical score of uterus. I'm repeating, biophysical score of uterus. When you will complete the infertility course, you will come to know that there is a biophysical score of uterus in which I have to see many things, plus to a myometrial contraction. A myometrial contraction is not an easy job to see on the live scanning. And here comes the role of the Cine lobe again. You will set it, you will freeze the image, and you will scroll down the Cine lobe slowly, and then only you will see that there are or there are not these muscle contractions. I mean, the myometrial contractions in the given this case. And one more important thing, to increase the measurement accuracy. How? You will scroll down and you will see where I am, having a better quality image. There only you will take the measurement, and that is possible when you will scroll down into the previous image, and that is the Cine lobe. So this was about the Cine lobe. Now, Dr. Prerna Chaudhary. Dr. Prerna Chaudhary is posting some questions, many questions rather. First question is, please explain with the help of image delineations of cervix in septate versus subseptate uterus. So the basic question is that where the indentations will be in case of a septate versus a subseptate uterus. Go to that relevant slide. Yeah, it is here. Now, the main difference between a septate uterus and a subseptate uterus is that the septum in case of a septate uterus. Now see, in case of a complete septate, will extend up to the cervix over here. Whereas in partial septate, it will not touch the cervix and it will be, somewhere in the center, but it will not be touching the cervix. So this is the graphical representation of the complete and the partial septate. So the main difference between the septate uterus and the subseptate uterus is that in a septate, a septum will extend up to the cervix, whereas the septum in a subseptate uterus does not. So that was the first question from Dr. Prerna. Next question is, kindly explain relation of ovaries with respect to the piriform, iliopsoas, obturator internus muscles. Now see, what this candidate wants to know is, we are having many muscles. Those who have not completed the gynae ultrasound course may not understand me, but those who have completed the gynae ultrasound course on server are knowing that we are having many pelvic muscles. When you will be putting the probe, you will not be seeing only uterus and ovaries. You will be seeing sometimes, many a times, the pelvic muscles also, and the rectus abdominis muscle, iliopsoas muscle, obturator internus, piriform muscles, and the pelvic diaphragm muscles can be seen. And what is the importance of these muscles? That sometimes they looks like a cross-cutted muscle will look like a mass, or sometimes it get you may get confused with an ovary also. So the question is, what is the relation? I'm elaborating the question. What is the relationship of the ovary with these muscles? Now try to understand. The ovary does not have any fixed location. So how can I say which muscle you will see with ovary? But most of the times, it is the obturator internus muscle which will be lateral to ovary. Is written over here. So the obturator internus muscle will be lateral to ovary. So it is the obturator internus which will be seen lateral to ovary. But repeating the first statement that ovary does not have a fixed location, so you can see any muscle with there. But as a general rule, it is the obturator internus which will be lateral to ovary. Next question from same Dr. Prerna. Dr. Prerna has sent us many questions today. It is about 5 to 6 questions posted by her. Now see, try to understand the question first. It is the question posted like, sir, air is hyperechoic. Now try to understand the question first. Air is hyperechoic or black on ultrasound. Now you tell me, you think air has to be more whitish or more blackish? It means that, is it more, if you will be clear with this point, then the rest of the questions will be answered. So you think, and others can chat in the comment box, what will be the echogenicity? What will be the color? I'm putting it very simple, of air on ultrasound. Will it be jet black, or will it be some whitish shade over there? In the comment boxes now, hurry up. In your comment boxes now, hurry up, please. Keep an eye on the comment box. Now, somebody is posting it jet black. Dr. Richa, whitish. Dr. Thomas, whitish. One more candidate, whitish, and Dr. Ellen, black. This is the point. You are getting confused whether it has to be white or black. It has to be whitish shade only. It cannot be jet black. Okay, so air cannot be anechoic. Air cannot be jet black. So if you will remember this thing, and if you will apply this thing, you will not get confused with your question. And the question asked is, the echogenic foci with a fibroid following uterine artery embolization is most likely due to air filling areas. So what type of shade and other things? So the basic point is that you are probably you are confused between the whitish shade and the blackish shade of air. So air cannot be anechoic. Air has to be towards the whitish shade. Now next question from same doctor is that it's like she is sending it like this. Sir, you told acute hemorrhagic cyst is hyperechoic. I'll try to understand the question first. You told acute hemorrhagic cyst is hyperechoic, but we know that fresh blood is anechoic or hyperechoic. Now, see, in hemorrhagic cyst, first clear the doubt. A hemorrhagic cyst means that the hemorrhage has occurred. Is this blood, whatever the hemorrhagic cyst is having, is that blood the dead blood or the live blood? When I say live blood means whatever is running in our vessels, and the dead blood is whatever has escaped and is filled in a space over there. Now, question: what will be the echogenicity of a blood in case of a hemorrhagic cyst? In your comment boxes now. I'm repeating the question. What will be the echogenicity of a hemorrhagic cyst which is having a blood, but that blood is not right now running in the vessels? What will be the echogenicity of a hemorrhagic cyst? In your comment boxes now. Hurry up, hurry up. We are having many questions. Hurry up. Dr. Thomas is telling me black. Dr. Richa is telling me black. Dr. Aiga is hyperechoic. Dr. Nidhi mixed. It cannot be. Hold on. Dr. Namita hyperechoic. Very good. Now, see, the point here is that the blood, whatever has escaped the arteries or any vessel, cannot be black. It is already a dead blood over there, and dead blood can be clotted blood also now. Now, the clotted blood has to be hyperechoic. Now, it depends on how fresh the blood is. But in no way it can be a hypoechoic or anechoic. So, if you clear this confusion, then the question will not arise. Okay. So this was the question. One more question, sir. It is mentioned in notes that a hemorrhagic ovarian cyst, circumferential blood is in the cyst. So this is already answered. So because you are having the basic confusion over in the echogenicity of a hemorrhagic cyst, which cannot be anechoic and which has to be hyperechoic or sometimes mixed, but it cannot be anechoic. So next is Dr. Vibha Singh. Dr. Vibha Singh is posting from Muzaffarpur. Dr. Vibha Singh is. Dr. Vibha is posting, in a fluid-filled space, how will I differentiate between blood and pus? So the point here is that this doctor is confused how I can see a blood, how the blood is looking like, or how the pus is looking like. You think first, if there is blood, the echogenicity of the blood, try to understand, the echogenicity of the blood will be defined by the age of the blood. Okay, if it is very fresh, then it can be hypoechoic. But if it is old clotted blood, it can be hyperechoic. But pus will not have a hyperechoic echogenicity, and the pus will sometimes show me some small tiny particles like in it, but the blood will not show me these smooth placed these particle like things. So this way you can differentiate between the pus and the blood. Now, the next question from same Dr. Vibha is that what is a phased array, vector, sectoral image, axial resolution, lateral resolution, temporal resolution? Now, see, I am very happy that these questions have been posted because it is showing you how much inclined towards this ultrasound you are getting now. The basic important point is that these questions will arise only and only, try to understand, these questions will arise only and only when the person is having a basic understanding of this physics of ultrasound. SPI. SPI is the first exam which you have to crack if you want to work in Western countries. And most of Indian doctors, if not a maximum of Indian doctors, are failing in SPI test only because they are very weak with the physics. I will say that this SPI exam to crack will take you about 6 months to prepare the basic, the physics for this SPI exam. So we are trying very hard since last 1 decade to introduce this physics, basic physics, not SPI physics, basic physics in Indian subcontinent. And I am today very happy that the people are now getting some basic information about this, and they are getting aware of that there is importance of this physics in day-to-day ultrasound scanning. Now, the point here is that first of all, there was the temporal resolution. What is the temporal resolution? And then one question was, what is the Doppler shift also? So you can note it down. I will tell you some basic things, very brief. What a Doppler shift is. The Doppler shift, also known as the Doppler effect. It is defined as a change in. Try to understand the points over here, the words over here. The Doppler shift, which is also known as a Doppler effect, it is defined as the change in the wavelength or frequency of waves with respect to observer who is in motion relative to wave source. That is Doppler shift. Temporal resolution. What a temporal resolution is? Temporal resolution is the ability to accurately pinpoint an object's location at a specific moment in time. And it is measured in hertz and typically referred as your frame rate. And that is the temporal resolution. Now, the next is, what is the next thing? Axial resolution. Now, the axial resolution is the ability of an ultrasound to differentiate between two objects that are parallel. This is very important, that are parallel to ultrasound beam. And this axial resolution is also known as longitudinal resolution. And the last was probably the lateral resolution. Lateral resolution is the ability of an ultrasound to distinguish between 2 points that are not now longitudinal but perpendicular to ultrasound beam. So try to grasp these technical things and this physics. And again, I am repeating, I am very happy you have to now prepare yourself for a better, digestion of this physics, because once you will be very clear with this physics, you can even crack ARDMS and you can work anywhere in world after getting an accreditation from ARDMS, and that is possible only with a good knowledge of physics. And in our ultrasound courses, we are giving just a basic of physics. Now, next question. What was the next question? Let me go to the question first. Yeah. Next question from again Dr. Viva. Dr. Viva is posting a question, has posted a question that how I can differentiate between a mucus plug and an IUCD. Mucus plug and an IUCD. How can you confuse a mucus plug with an IUCD? Now see, this is an IUCD. This IUCD, first of all, if it is in cervix, it is displaced. So the question has to be how I can differentiate a displaced IUCD from a mucus plug. Mucus plug will look like a echogenic, but not hyperechoic. Try to understand. It will be a not a hyperechoic, but more echogenic as compared to myometrium or the cervix over here in given here, while the IUCD is very, very hyperechoic structure. And from IUCD, even I can sometimes see the shadowing, whereas no question, no point of having shadowing from this mucus plug. So how can you confuse a mucus plug with an IUCD? IUCD will look like a more echogenic and well-defined margins. So we have next question. Again, Dr. Viba's question. How will I see a reverse venous flow? And next question, how will I differentiate artery from a vein in a color Doppler? First, the waveform. Those who have completed the or undergoing the color Doppler will understand me better. And those who have not touched it yet, please, if you are not understanding, you can ignore for now. Now, this is the baseline over here. This is the baseline. If I am having a wave, now see, if I am having a wave which is crossing this baseline, that is reversal. But what if whole of the wave is on the other side? That is not reversal. That is an inverted wave. So the basic point to understand is that if the wave is crossing this baseline to another side, if it is crossing it, then it is reversed. Otherwise, if the whole of the wave is on the other side, that is just an inverted wave. Next question is that how I can differentiate an artery from a vein. Very simple. The vein will have a venous type of flow and the artery will have an arterial flow. But don't confuse with colors. Artery will not have a red color and vein will never have only a blue color. So red and blues will not tell me whether I am dealing with the flows, with the artery and veins, but it is the flow itself which is taken, the pulse flow I mean, which will differentiate the vein from a artery. And these things are in detail in the physics of color Doppler. And the color Doppler course in itself is about a 1 month course. Okay, now next set of questions from Dr. Arpana. Dr. Arpana is sending us question. Please show the image of a thin myometrium in placenta accreta. Thin myometrium in case of a placenta accreta and the secondary abdominal pregnancy. Now, this candidate has probably completed the gynae ultrasound course because this is the last topic of the gynae ultrasound course. Now, over here, what I am seeing over here, this is the normal myometrium. This is normal myometrium. This is normal myometrium. This is a thin myometrium. And if this myometrium is less than 2 millimeters, then it is thin. Why this is important? It is in placenta accreta, very, very important. So see for the thin myometrium, and this is the picture of a normal for comparison. And this is now see, this is the myometrium over here, and this myometrium will be hypoechoic. So it is the hypoechoic zone which you have to measure over here. So as requested, this is the normal and this is the thin myometrium over here. And the next question from same doctor is that the secondary abdominal pregnancy. Now, when I say secondary abdominal pregnancy, yeah. Am I audible? Am I? So, in a first trimester or in an early pregnancy, it is very easy. I will say very easy to pick an secondary abdominal pregnancy. So this is the fetus over here, and this is the empty uterus. But Done. Now, the point here is that in a third trimester, I may not see, and I will not see, not may, I will not see a uterus which is empty so that I can make a diagnosis of a secondary abdominal pregnancy. The only thing, this thing is discussed in, fetal ultrasound. There is a complete class on this. The only and only retroplacental space. If I am having a missing myometrium behind the placenta, will tell me that you are dealing with a secondary abdominal pregnancy. So secondary abdominal pregnancy can go up to term. So the only thing what will hit my mind that maybe that I am dealing with a secondary abdominal pregnancy is the retroplacental space. I mean this myometrium, which will be missing in case of a secondary abdominal pregnancy. And same is true for the placenta accreta. So by having a look onto the placenta for what? For this myometrium, you are hitting two birds with one stone. And one is your placenta accreta, and second is the secondary abdominal pregnancy. I know that almost all gynecologists are very scared with this placenta accreta, and most of times, unfortunately, it is what getting missed. Why it is getting missed? Because you guys are not seeing to the placental myometrium. So make a habit to see this this myometrium beneath the placenta. Now, next question is how to differential diagnosis of fluid in an endometrial cavity. Now, see, fluid in an endometrial cavity, what can be the causes of the fluid in the endometrial cavity? First is the hormonal imbalance. Sometimes there is fluctuation in this estrogen and progesterone levels. It can cause up a buildup of this hormones, especially in the menstrual cycle. Sometimes due to their pelvic inflammatory disease. Sometimes I may have fluid in a post-menopausal change, as in post-menopausal change. Sometimes due to some congenital abnormalities, which is preventing, which is preventing the drainage. These congenital abnormality, which is preventing the drainage, will lead to the endometrial fluid accumulation. Sometimes some malignancies in endometrium or cervical, maybe that there's a cervical cancer, which is not allowing the endometrial cavity to empty, will lead in the endometrial cavity fluid. Sometimes the cervical stenosis, maybe that there's a polyp which is obstructing the fluid which is getting produced high up. Sometimes maybe that there is a submucosal fibroid. So these are the points which you have to keep in your mind when you are seeing for an endometrial fluid. So endometrial fluid, not to just report as that there is endometrial fluid, you have to exclude that there is no endometrial polyp in that given case, there is no fibroid which is obstructing, and there is no congenital abnormalities which is also which can be also a cause of the endometrial cavity fluid. So last question is what will be the differential diagnosis in case of a mixed echogenicity mass lesion in the uterus with cystic area? So if you are having a cystic area, not a cystic area, heterogeneous area with cystic components, she means there are many things which you have to keep in your mind. And first is maybe that there is a retained placental tissue. Okay. First is that there may be a retained placental tissue. Sometimes there can be a malignant mixed Mullerian tumor over there. And sometimes it can be the result of the uterine fibroid. And maybe that there is a uterine sarcoma. And maybe that there is a uterine vascular lesion, which is, this uterine vascular lesion can be sometimes due to some, cesarean section deliveries, or maybe some DNC has patient has undergone, and with the result, I will be having the uterine vascular malformations, and I will be seeing in heterogeneous area with these cystic structures, and other causes can be due to the endometrial carcinoma as well. So these are the list of pathologies which you have to keep in mind when you are seeing a mixed lesion heterogeneous lesion with some cystic lesions, and most of times it is there, most of times, but not always, most of times it is the fibroid with some degenerative changes, but it can be even the carcinoma also, which will be leading to the this type of picture. And the color Doppler will tell you if the color Doppler vascularity is increased, it can, it is giving you the signal that there are chances of malignancy. And if color Doppler is flow is low, that is going against the malignancy. So these were the questions from our registered candidates. I'm very happy, really. I'm very happy that people are getting some interest in physics. Physics is the backbone of ultrasound. Without physics, you cannot do a good ultrasound, and ultrasound is not about photography. It is the real test of your neurons. Know your subject, know your knobs, know the basic anatomy, know the correlation of the pictures. If I'm seeing this thing, next I should see this thing, and if this thing is not seen, it means that I have to change whatever I was thinking previously. So we are having these types of sessions on regular intervals. Have I missed any question? Yeah, one question is over there. How to measure previous cesarean scar thickness on ultrasound? We have taken a detailed, very detailed. This is a question itself posted, but it is not a question. It is a topic, a small topic in itself. We have this class over here, and we are going to upload it on our server. So please go through that in near future. We will, intimate you whenever it is uploaded on the server, because this is not a question, but a small topic in itself. So thank you very much. In case you'll be having any question, please post to our helpline number prior to the announcement of our interactive sessions, and requesting you not to post any question from the topic which you have not touched yet. Okay. So if you have completed the topic, for example, you have completed the color Doppler, or you are undergoing color Doppler, you are most welcome to post. But if you are in gynae ultrasound only and you are posting a question from color Doppler, does not make any sense. So better to complete and at least start the topic before posting any question. So thank you very much. God bless all of you. Bye-bye.